Okay, let's just jump right in. Picture the entire economic output of a medium-sized country. Got it? Well, back in 2017, the United States spent an absolutely staggering $3.5 trillion on its healthcare system alone. It's a massive, almost incomprehensible number, right? And, when you hear a figure like that, you naturally assume it's funding a perfectly oiled machine, a system completely optimized to keep every single citizen healthy, active, and thriving.
But here's where the dramatic tension really kicks in. Out of that massive $3.5 trillion pie, guess how much was actually dedicated to government public health activities designed to prevent illness? A tiny, almost invisible 2.5%, just 2.5%. We are literally spending trillions of dollars scrambling to restore health after prevention is already broken down, rather than investing in keeping people healthy in the first place.
Welcome to This Explainer. Today, we're setting the stage to demystify the incredibly complex, deeply intertwined web of the U.S. healthcare system. We're going to look at the structural flaws in how we approach health, how we pay for care, how we're forced to make absolutely impossible ethical choices, and finally, how modern digital architects are trying to redesign this whole shebang from the ground up.
So, here is our roadmap for today. First, we'll look at the prevention puzzle, then funding long-term care. Third, medical ethics and rationing. And fourth, the digital systems architect.
All right, let's dive into part one, the prevention puzzle, and why we always seem to be waiting for things to break down.
So, why exactly does our medical system wait for prevention to fail before stepping in? Well, consider the base of former CDC Director Thomas Frieden's health impact pyramid, socioeconomic factors. Improving the standard of living, creating jobs, ensuring a living wage. These things prevent illness far more effectively across a population than top-tier clinical interventions. Yet the traditional medical model focuses almost all its resources right at the top of that pyramid, doing things like counseling individuals to change their diets or just prescribing medications. It's essentially a system that targets high-risk individuals instead of addressing the broader societal context that makes them sick to begin with.
We can see the true cost of ignoring that foundation when we look at the surprisingly small number of preventable lifestyle risks that drive the vast majority of chronic disease mortality. Just look at these numbers from 2016. We had 480,000 deaths from tobacco, 460,000 from poor diet and inactivity, and 88,000 from alcohol. These are our modern epidemics, and while clinical medicine desperately tries to treat the resulting heart disease and cancer, public health advocates argue that we need broader, societal-level changes, things like taxing sugary drinks or restricting tobacco advertising, to truly make a dent in those massive numbers.
Which brings us to part two, funding long-term care and the absolute financial crisis surrounding it.
As chronic diseases rise, more and more people need daily assistance, and that's creating a massive financial bottleneck. To understand the human stakes here, consider the tragic story of Eddie Taylor. Eddie worked in a men's clothing store for 50 years, diligently building up his life savings. But after a devastating stroke, he was left paralyzed and unable to speak. His spouse simply couldn't physically care for him at home anymore, so Eddie had to go to a nursing home. But here's the catch. Because his care wasn't considered hospital level, Medicare wouldn't cover it. At $245 a day, Eddie and his partner had to completely impoverish themselves, spending down 50 years of hard-earned savings, literally just to qualify for Medicaid. And once he was finally on Medicaid, the low reimbursement rates meant Eddie was placed in an underfunded, dehumanizing environment where his condition severely regressed.
Eddie's story brilliantly and brutally exposes a massive financing gap in the U.S. system. A lot of people falsely assume Medicare covers nursing homes. Actually, it doesn't. Medicare only covers short-term, skilled care. Think physical therapy after a hip replacement or getting IV antibiotics. But if you need long-term custodial care, like help with bathing, eating, or getting out of bed due to a chronic condition, Medicare leaves you totally stranded. You are essentially forced into destitution, so Medicaid will finally step in to cover those basic needs. It is a catastrophic structural failure.
And this isn't just some abstract system failure. It's a huge burden falling directly onto the shoulders of everyday families. Right now in the U.S., there are roughly 44 million informal, unpaid family caregivers, daughters, wives, husbands, who literally have to quit their jobs or reduce their hours to care for loved ones. The estimated economic value of all that unpaid labor, an astounding $470 billion annually. They are single-handedly propping up the entire long-term care system, very often sacrificing their own financial stability and mental health to do it.
So, these financial gaps force some impossible choices, which brings us to part three, medical ethics and rationing.
To navigate these systemic gaps, healthcare providers constantly have to balance 4 core ethical principles: beneficence, which is the obligation to help the patient; nonmaleficence, the duty to do no harm; autonomy, meaning respecting the patient's right to choose their own care; and finally, justice, which is ensuring the fair distribution of limited resources. Now, in a perfect world with endless money and unlimited resources, these are pretty easy to follow, but out there in the real world, they constantly collide.
These principles clash incredibly painfully in micro-level situations, like the tragic case of the Lakeberg twins. Born conjoined and sharing a single heart, the medical team faced a literally impossible situation. Surgery guaranteed one twin would die, and it gave the other a less than 1% chance of survival. Still, the hospital proceeded with the surgery, costing $1 million of society's money, and tragically, the surviving twin died just a few months later. This is a profound ethical dilemma. It's prioritizing individual beneficence over societal justice. You have to ask the hard question. Could that $1 million have been spent immunizing thousands of children, yielding a much greater overall benefit?
This brings us face to face with the harsh reality of micro-allocation and rationing. Imagine you're in a rural hospital with exactly one available respiratory. An elderly patient with terminal cancer is currently using it, but she's actively deteriorating. Suddenly, a healthy 27-year-old arrives with a crushed chest from a car accident, and he needs that exact respirator to survive. So who gets it? Practitioners are forced to make these immediate, tragic decisions based purely on commodity scarcity and medical effectiveness. They literally have to weigh doing harm to one patient against maximizing the benefit for another.
How do we even begin to solve these massive failures? Let's look at Part 4, the digital systems architect.
To fix this, we really need a completely new blueprint. And the latest healthcare policy updates reveal a potential solution, reframing the modern practitioner as a systems-level architect. These modern architects leverage predictive AI, they evaluate digital quality metrics, and they use hyperlocal data to map out social determinants of health in real time.
By synthesizing these continuous streams of digital data, everything from electronic health records right down to your wearable smart devices, this new architect can actually forecast high-cost patient trajectories. Instead of just waiting for a patient to end up in the ICU and forcing another tragic rationing decision, they can intervene early. They are shifting from reactive, traditional financing to dynamic health informatics, which lets them allocate resources efficiently and equitably way before those acute, expensive interventions are even necessary. But, and this is absolutely crucial, they also have to rigorously scrutinize these clinical algorithms for inherent biases to make sure they don't accidentally make existing health disparities even worse. Which brings us right to the frontier of health policy. If an AI can predict exactly who will cost the system the most money, and who is most likely to actually benefit from a treatment, how do we use that data? I want to leave you with this final provocative thought to ponder as we step into this powerful new era of digital health economics. As AI predicts our health trajectories, will it truly make our care more equitable and preventative? Or will it just change the mathematical equations of how we ration it?